Professor Duat needs no presentation, so let's hear him.
So all of us know that Dalk is now the gold standard for patients who have a normal endothelium yet need keratoplasty for whatever reason, scars or ectasias. When we do Dalk operation, there are three main techniques: air injection, viscodissection, or a mechanical or manual approach. All of them attempt to reach the deepest plane, as deep as you can, to the pre-Descemet's layer or the Descemet's membrane. And a lot of information on the techniques and this science and surgery are in these two references. The first one is a book chapter, and the other is in Progress in Retina and Eye Research, which is free to download from the internet. Now let's look at Dalk by air injection. What happens when you inject air? If you look at it minutely, and these are human eye bank eyes, you will find that air moves from the center in radial tracks towards the limbus. And this can be in a compact cornea in the form of fine, like cracks in a glass line, or more diffuse. Once it reaches the limbus, and here you can see one track, it then goes clockwise and anti-clockwise to make a complete circle. And when you it forms that circle, which is quite unique, it tells us that the microanatomy of the periphery of the cornea is different to that of the center, because this is a very consistent manner of spread of air. And if you do a section across that, what you find that this part of the periphery is more aerated than the center, and you see all those bubbles accumulating at the periphery. That's the part of the cornea, 1.5 to 2 millimeters, where it becomes prolate, and is also the thicker part of the cornea. Then the air moves centrally from here, collects in the form of tiny bubbles, which coalesce to form a central bubble, which then lifts up to form a large bubble which extends between 8 to 9 millimeters but doesn't go beyond. Sometimes a thinner bubble forms at the periphery and then extends across the entire surface of the cornea, and occasionally you get the two together, a thin one at the periphery and the large central one. The bigger one, this one is called the type 1, the thinner one is called the type 2, and this is the mixed, where you've got a complete lift of the Descemet's and of the pre-Descemet's layer over here. This, as you can see, is the histology of that, the air and the pre-Descemet's layer from which the endothelium has been Descemet's membrane has been removed. So that's a thin layer that we're talking of, which is usually exposed in the Dalk operation by air injection. Now, if you take away the Descemet's membrane and you make the eye upside down, the cornea that is, inflate it and do phototherapeutic keratectomy for about 20 microns, and then inject air, you can never get a type 1 bubble. So it's telling us that that layer is important for that bubble to form, and it is quite unique, and it's not a random separation of the stroma. Now, this is what happens in the human eye. You see that circular movement is coalescing in the center, lifts to form the type 1 bubble. And when we do Dalk, as Nicholas just showed you, you're injecting air. Now, because there's a cut in the cornea, so the air may not go to the periphery, but you get that bubble with a white ring. You take the top off, you puncture the air, you puncture the bubble, release the air, cut it into 4 quadrants, and you take that and put the new cornea. So what you've exposed there is the anterior surface of the pre-Descemet's layer. Now, this layer is quite tough. You have to push the pressure up to 700 millimeters of mercury to burst it. Now, that's very reassuring, because during Dalk, you can do a lot of maneuvers and preserve that layer and not damage it. And even if you get a minor perforation, you can carry on with the Dalk and complete it successfully. And because of that toughness, you can also do the whole cataract operation with implant under the pre-Descemet's layer. When you're doing a Dalk in a scarred cornea and you cannot see through to do the cataract, people have done this triple procedure. We published on this, called it the Dalk triple procedure. You can do, but you cannot attempt this when you get the thin type 2 bubble with the Descemet's membrane only. It's only the pre-Descemet's layer that will allow you to do that and complete the procedure, both cataract and the Dalk. Now, what happens in other occasions, you'll see here that circular movement, and then the bubble starts at the periphery and goes across the entire posterior surface. So this is where air is accumulating anterior to the Descemet's membrane, and this is the type 2 bubble. It goes all the way to the periphery, and it's important to know because in the human eye, when you're doing this, you'll see you get a clear bubble margin with no white, and it goes all the way to the periphery. Now, if you're going to do paracentesis in these eyes, you're very likely to rupture the descemet. So you have to be very careful not to do a paracentesis unless you've released the air and everything has moved anteriorly so that there's space for your paracentesis knife to go in without rupturing the bubble. And this is what happens if you're not aware, and this has happened when we were not aware of this kind of bubble. Now, the first one is from Kana Ramesh. Kindly loaned me this video, and you can see what's happening here is that the cornea has been put, he moves the eye to one side, and just that pressure allows the descemet to burst. Now, tells us that this type 2 bubble is very weak, and one should not undertake too many maneuvers when you're doing that. And then this one over here, you will see a nice bubble has been attained. I'm trying to trim the edge, and look, the whole thing goes. This is what happened with the Descemet's membrane. It never happens with the type 1 bubble with the pre-Descemet's layers there. But not only has it burst 360 degrees, and you can take the whole Descemet's membrane off. So very important that we constantly lower the pressure through the paracentis by releasing aqueous and keep the Descemet's membrane flaccid so that you can successfully complete the operation. Sometimes if your trephination does not reach the bubble does not reach the edge of the trephination, you will see strands extending between the posterior stroma and the anterior surface of the pre-Descemet's layer, which have to be cut or teased off. This will only happen with a type 1 bubble, which fortunately is 85% of the times, and it also helps you, these strands helps you distinguish between a type 1 and a type 2. When you see a rough surface like that, you know you've got a type 1 bubble. If you see a very smooth surface like that, it's a type 2 bubble. This is where you have to take all those precautions. And these are just some scanning and transmission EM pictures to show you those strands extending between the bubble wall and the stroma. This is mixed bubbles where you get a type 1 component centrally and a type 2 on the periphery. And this is one example, a video lent to me by Tariq Katamish, where clinically how this type 2 will look. And you can see the top has been taken off, but there's another bubble underneath. And as you release that, you can see the Descemet's membrane. So there were 2 bubbles over here. You can peel off the Descemet's membrane entirely from a type 1 bubble like this. It doesn't burst, telling you that the pre-Descemet's layer is impervious to air. But when you do histology of the Descemet's peeled from a type 1, a type 2, or a mixed bubble, it's completely intact. There's never a split between the banded and non-banded zones, which was the explanation provided for a mixed bubble. This pre-Descemet's layer continues as the trabecular meshwork, and there are fenestrations at the periphery like so, and these fenestrations are what allows air to escape and cause the type 2 bubble to start at the periphery. You can see if the Descemet's attached there, air will escape from the fenestrations, collect anterior to the Descemet's membrane. Sorry, here in this case, the air will go in the anterior chamber in a type 1 bubble. But if the Descemet's is attached here, it will collect anterior to the Descemet's membrane, cause a type 2 bubble. So it explains why sometimes you get one type of bubble and sometimes you get the other. What about viscodissection? When you do viscodissection, just 2 slides to tell you, the depth of the needle is very important, or the cannula. If you are in the anterior stroma, you get a diffuse spread without a bubble forming. If you are in mid-stroma, you can get either a diffuse spread or an intrastromal big bubble. It just rips apart the stroma and you get what looks exactly like a type 1 bubble, but you've got a variable amount of stroma at the bottom. And you have to be wary of that, and only OCT will tell you, as you see over here. If you are really deep, then you can get a type 1 bubble, but it's extremely unlikely to get a type 2 bubble, which means viscoelastic accumulating anterior to the Descemet's membrane with viscodissection. So you will get a type 1 or an intrastromal bubble, and you can see the amount of stroma left behind. On the table, it may look like a type 1, and you may end up with a lot of thickness and irregularity in the depth. What about the third technique, the manual technique? When you don't get any kind of bubble, then things can happen which can give you a little extra help, like you see over here. Air went straight into the anterior chamber, so you come out, inject air at another point, you get a small intrastromal bubble, so that's very good. You release the air in that small bubble, and then mechanically with a spatula, you can dissect all the way around like a type 1 bubble and get exactly the same result. This is another approach which Rishi Swaroop sent this video to me. If you're deep enough, visco bubble was tried, it didn't work. You can actually physically peel off the entire stroma from the pre-Descemet's layer, and you can create what was the equivalent of a type 1 bubble end result. So there are other mechanical ways which are not, which are few of them which I can't cover all in this talk, but mechanical separation, exploiting that cleavage plane is possible if you don't get any type of bubble, and you can more often than not end up with successful type 1 equivalent of the Dalk. So in summary, knowledge of the posterior corneal anatomy is key to understanding corneal surgery, and we know now corneal pathology, and the pre-Descemet's layer, Descemet's membrane, posterior corneal stromal relationships are important in lamellar keratoplasty, whether it's Dalk or endothelial keratoplasty, and it's helped in planning, designing, developing surgery. So all this information will help you understand more of what you see during the operation and help you to improvise and change your technique to adapt to the situation as it develops during surgery. Thank you.